That's us. That's us up and running on Facebook as well. So thank you very much for joining us today, Professor Jones. I missed you last week, unfortunately, so it's really nice to be back this week. And I was waiting patiently to see what you would put in as your description for joining it. But I think because the people on Facebook missed your fact of the day, I think you need to share that with us again.
Yes. So for those of you of a certain era will know that the lead singer of the Monkees was Davy Jones, which was not me. I wish I had his money. But my obscure fact of the day is that David Bowie was also called David Jones. He's one of the collection of quite famous people in the world called David Jones. I exclude myself from that. But he wasn't allowed to use the stage name Davy Jones because Davy Jones from the Monkees had already got that name. And so he became David Bowie. So they're obscure fact of the day. And for those, I don't know if you have anybody from Australia on today. Please put your hand up if you have.
Maybe, yeah.
The smartest shop in Australia is called David Jones. That's where my name amuses all people from Australia. And when I went out to give a talk in Australia, I went into David Jones, and I thought, being me, for those of you who know me, I slightly wind up the person behind the till. And so I bought something and I handed over my credit card and I said, but of course I don't really need to pay for it. And she said, what don't you need to pay for it? That's about what I said to do, apologise, cultural appropriation, all that. And she said, what don't you need to pay for it? And I said, well, I own it. And she said, no, you don't. And I said, have a look at my credit card. And she said, have a look at my credit card. And she went, you own it. And I said, no, but it was a good try, wasn't it? So there you go. David Jones in Australia is a famous department store. There you go. It's like Harrods. So none of which. There you go. Right. To business.
Right. Down to business. Yes. So just before we get started, I always just like to remember that these Q&As do not take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. Remember too, please, if you're joining us on Facebook, it's a public forum. And if you want a bit more privacy, you can join us here in the room and click meet in. So I'm going to get started on the questions that have been sent in.
Before we do that, can I just say hello to New Brunswick? I think that's a new one on us. Hello, New Brunswick.
Yes, I think that is a new one on us. Yeah.
Everywhere.
We do. So I've got a general question, but I've also got, it links into 3 questions that we've had this week, and I think we actually covered it in another recent one as well. So I'd like to make a little mini video, because we're at that time of the year again where people are getting the reminders about their COVID jags and stuff like that. Yeah. So I'll read you what we've got, and then if we could cover those in the answers, but then also sort of just a general one. So one patient has gotten in touch to say that their nurse says not to have the COVID jab, and that advice has been given to all liver patients. She wanted to check that was in line with our understanding for PBC. So she's had advice from our nurse not to have it. A general one around, is it recommended that you have the COVID-19 and your flu boosters when you have PBC? And also another patient asking if they're entitled to the free flu and COVID injections, and also would potentially her husband also be entitled because he's her carer.
Okay, right. So it's that time of year, isn't it?
Yeah.
And over the years, vaccination crops up as a frequent topic. And I'll say what I always say when we talk about vaccinations is that the 2 things that have transformed human health in the last 200 years have been access to clean water and vaccination. So not statins and antibiotics and things like that, all of which are useful, but those were transformative. So in population terms, in general, vaccination has transformed people's lives. However, like everything in life, at a population level to an individual, as you get down to the individual person, it becomes a little bit, less clear. Okay, so COVID vaccine first. I think we've talked about this much, over the years, and where I am with the COVID vaccine, and this is a personal view. Okay, so normally I'm very clear where it's kind of an orthodox view in PBC. So 99% of what we talk about is what I would regard as the orthodox view, in the field. And if because I think that's very helpful to people. And there's certain things that are around a personal view. And that's partly because we don't know the answer. And I think it's really important for doctors to say, be honest, if where we know the answer, say this is the answer as we understand it, where we don't know the answer, also be honest with it. So my personal view with the COVID vaccine is that, and this I speak as somebody who managed, a COVID ward at the height of the first wave of COVID, is that this was a truly awful disease in that first wave. And, you saw things that you never, ever want to see again. In that situation, what changed it was the advent of the COVID vaccines. Now, those vaccines did not stop people getting ill from COVID. It did not stop COVID being a horrible, flu-like illness, but it did stop people developing the complicated forms that put them in ITU and killed them, in simple terms. So it changed the disease. It didn't stop you getting it. It changed the nature of it when you got it. And I think that's why, with the power of hindsight, which is always 2020, things like the COVID mandates and passports, and you can't go into a bar unless you've been vaccinated, in fact, were nonsense, because the vaccine didn't stop people getting it. It just stopped you dying from it. And I think that's important to realize. So now I think those forms of really horrible COVID that we saw at the beginning, where people had real breathing troubles, clots in their lungs, and so on and so forth, we just don't see that anymore. What we do see is what we've always known, is that people with health problems will get chest infections, and chest infections can be bad for you. So are there people dying at the moment who have COVID on their death certificate? Yes. Are they dying of COVID? Possibly. Is that similar to flu or bronchopneumonia or something? Probably. So you've got to distinguish between somebody in whom a variant of COVID is a direct cause of their death, or a factor in somebody who is ill. I think that's important, because it does change what we do to it and respond to it. So on that basis, I think it was absolutely right that people got the vaccine early on, and actually PBC patients were absolutely fine with the vaccine. I'm not sure where the guidance not to take the vaccine comes from. That's not advice I would give to anybody. So vaccine was transformative for this. I think the need for ongoing vaccination is less clear. Okay. And the reason for that is twofold. One is, what are we preventing? Given that we can't prevent people getting it, we're preventing a type of the disease we don't really see anymore. And then the other, of course, is the extent to which any vaccine covers the variants that have emerged. And what I think is, there's too much controversy about COVID, too much almost politics in it. But COVID seems to have done what viruses always do, which is mutate into a less severe form of it. And that's the rapid evolution of viruses, because a virus that kills people is not a very effective virus, because all a virus wants to do is to basically make baby viruses that go on to infect other people. And if you die of an illness, you don't go out and infect other people, so the virus dies out. What you really want to do is have people go out and cough and sneeze, and but still meet other people. So COVID is doing what Spanish flu that caused us the problems in 1918 is still around, but it's a much milder form, because that's what viruses do. So the benefit of the vaccine is probably less than it was at the beginning. The risks, I think we're still starting to understand. What do I think? I think there is with the kind of RNA virus vaccines that people talk about, I think there are undoubtedly rare people who get a cardiomyopathy from it. I've seen it myself. Rarely. I think with the AstraZeneca virus vaccine, I think there are undoubtedly clotting problems. We don't use that vaccine anymore, but they are rare. So like with literally everything we do in medicine, it's a risk and benefit. Take an operation for appendicitis, okay? You think, on the one hand, what's the benefit of having an operation of appendicitis? You don't die of appendicitis. What's the risk? Well, people will react to an anesthetic. There is a risk. There is a benefit. You weigh it up. Antibiotics for meningitis. You could avoid dying of meningitis, but you could have an allergy to the antibiotics. There is a risk and a benefit to everything, but those are examples where it's really clear cut. To me, the early days of COVID, it was really clear cut. I think it's less clear cut now. Have I had a recent booster for COVID? No, I haven't actually. My wife is an intensive care consultant, ran a COVID intensive care unit. She's not had a booster for COVID. You can make of that what you will. Flu, it's always been slightly more marginal flu vaccination. At a population level, it reduces the severity of flu. But we all know, years when the vaccination is good and vaccination is less. I don't think there's as much controversy about the flu vaccine. I think it's a safe thing. It's just the question is, the risk and the benefit ratio. So I think it's up to individuals. To me, neither of those are absolute, you'd be crazy not to things. And I think it's reasonable to ask yourself how you feel with it and what you feel about it. And I think some of the hot air needs to come out of vaccine. I am not in any way, shape or form an anti-vaxxer. Please do not take that as the message. That's why I said vaccination has been one of the things that transformed, our human existence. And I've said frequently on these things, when I started as a junior doctor in 1988, we still had iron lungs on the ward for people with polio. Okay. And that sounds like something out of the 19th century, and it was, but that's the only way you could keep people alive. Vaccination made that go away. But its risks and benefits. So, yes, I don't think it is what it's worth anything specific to do with PBC about vaccination. I don't recognise the idea that you shouldn't have a vaccination for COVID because you've got PBC. I think you should have it on the risk and benefit. And as I've said before, COVID didn't particularly badly affect PBC patients, with the caveat that that's probably not true about people with cirrhosis, and it's certainly not true about people after transplant or who are on transplant type medications. It's a different game in that situation. In those situations, I would certainly have the vaccine. So that's where I am with it. As to who's eligible and who isn't, I am not the right person to guide about that. But it sounds sensible to me. I think if you've got chronic chest problems as well, that the importance of, say, a flu vaccine is that much greater. And if a carer can have the vaccine, prevents them from getting it and infecting you, so much the better. It's all about risk and benefit. And the benefit is an individual thing, and the risk is often difficult to predict. But there are too many strongly held opinions out there about this. And I think a little bit of kind of evidence about it would be useful. I hope that makes sense. So the answer on balance, probably, but at the end of the day, it's an individual decision, and none of these things are a no-brainer, as COVID vaccine was at the beginning.
That's great. Thank you. I also wanted to I think we covered a question on this recently as well, but we are seeing quite a lot of questions come in about this, and it'd be quite good if I could create, I'm making you work today, another little mini video, which is around questions about weight loss injections. So we're seeing a lot of queries coming in about that. So we've seen reference to all the different names. So Ozempic, Mounjaro, semaglutide, and Wegovy, but just all of the GLP-1 medications. The two specific questions that we've had in this time, diagnosed with PBC last year and responding very well to Urzol with no side effects. Specialist recommends that I lose some weight. However, it's been an unsuccessful struggle. Yeah. Is it safe to take Ozempic? Yeah. And then also just a general one around slimming injections as well. But it is something that's come up quite a lot recently. I just think maybe with the more use of these medications.
Okay. Just a comment from somebody who's had a liver transplant and was advised to take the vaccines. Absolutely, because of immunosuppression. And as I said, it has to be individualized as a thing. But
I'm actually also just recovering from a bout of COVID, and it wasn't very pleasant this time at all. So if it was, I would say probably this time, I've had it once before, this time is probably worse than the time I had the last time. So
yes, I think this is a moving, sorry, back onto COVID vaccines. This is a bit of a moving target because the different variants. I had it a couple of months ago and it knocked me for 6. So it may be that there's a different variant, but we're not getting complications. Here we are having a conversation about we're not getting complications from it. I think that's that nobody doubts that COVID can be a really miserable thing to have. There's no doubt about that. But it's whether it's putting you into ITU or not, and that's the key thing. Right.
And also, just quickly before we move on, if you are post-transplant, you're eligible for the antiviral medication as well. So if you are post-transplant and you get COVID, make sure you ask about that as well. Right.
Right.
Slim injections.
Weight loss injections. Very topical question. And I'll give you a science answer and I'll give you a kind of process answer. So the science answer, so the question is, everyone is familiar with Wegovy, and so, and Ozempic and all of these various different things, okay? And so the question, the first question I'll deal with is, are these safe in liver disease, okay? Now, from a medical scientific perspective, well, there have been very large trials of these as a treatment for fatty liver disease, okay? So they have been used as a therapy in liver disease, and they were very safe and effective. So that would tend to answer the question, because if they've actually been trialed in people defined by having liver disease, and those trials were successful and the drug was safe, it would tend to suggest it's safe, okay? Now, the usual caveats for any drug is that there are two forms of liver disease, essentially. There are those with cirrhosis and those without. Now, with PBC, the majority of people don't have cirrhosis. That's why the name was changed. Now, there are some people with it, but the majority don't have it. And people with cirrhosis split into two groups, those with complications and those without. So basically, there are three groups of people with PBC. The majority don't have cirrhosis. And then of the rest, the majority who do have cirrhosis don't have complications. And then you've got a small group of people with complications. Okay. Now, in general, all drugs are less well handled when you have cirrhosis, and they tend to be badly handled if you've got cirrhosis with complications. So I would tend to avoid any therapy out of the ordinary if I had cirrhosis, and I would absolutely avoid them if I had advanced cirrhosis. Okay, now I can't remember off the top of my head the fatty liver disease trials. I'm not a fatty liver disease doctor, but I'm not aware whether they excluded cirrhosis, but I would imagine they probably did, because the drug handling is more unpredictable. But for people who don't have cirrhosis, these drugs were very safe and were very effective. And obviously there they were being used to treat fat deposition in the liver, but lo and behold, they also worked to help people lose weight, which is why they worked for fat in the liver. So that's the science answer. The non-science answer is that the labeling for these drugs say avoid in liver disease, which is illogical. Now, how can I say that they are safe in liver disease because they've been trialed and yet the label says they're not for use? That is drug companies covering their backs, okay? Because they haven't been evaluated in every other liver disease. So there are companies making a lot of money, as you'll be aware, out of these drugs. And so if you were to have people with liver disease who had complications, even if it was unrelated to the drug, it would damage that. So, it's like you read almost any drug leaflet, drug inserts in a drug pack, and it will say, unsafe in pregnancy. Okay, not one of those drugs has ever been trialed in pregnancy, and there is no evidence they're unsafe in pregnancy, but there is no proof that they're safe. How do you prove a negative? And so essentially, as a catch-all, if they don't know something is safe, they presume that it's unsafe. It's like those signs we see nowadays to say we can't guarantee that there are no nuts in this, even though there are no nuts in it, right? Well, how do you use that information? So for people with nut allergy, so it's a catch-all. So there is no evidence, that these are unsafe, but they are said to be avoided in liver disease. And I've been caught out with this by saying to people in my clinic where they've sort of wanted to look at this as an option, and I said it's fine for me. I've trials in liver disease, etc., 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 and then they've tried to get them and been told you can't because you have liver disease. So I think it needs an intelligent discussion. I would avoid them in cirrhosis. I would absolutely avoid them in cirrhosis with complications. So I think it's one to have a discussion about. Are they useful for losing weight? They are. They're not a magic bullet. Nothing ever is. And a lot of what they do is basically make you feel sick all the time. And that means you don't want to eat. So they are not a magic way of losing weight. They are something useful, and they work for you and may help with it, but they're not a magic bullet, right? The other question often is about bariatric surgery, so obesity surgery in its various different forms. The answer is going to be exactly the same for a variety of reasons to do with, varices risk and things like that. You want to avoid those in cirrhosis, okay? Because you can get varices on the abdominal wall. They do an operation, you end up with a mess. But those are perfectly straightforward and safe, as any other surgery is in people with PBC who don't have cirrhosis. So these things are at a population level very useful. They are not an easy solution, far from it, but they are a useful option for people. And generally speaking, from a medical point of view, they are safe in people with non-cirrhotic PBC, but you may find people are reluctant to use these approaches in people with cirrhosis from a not a terribly informed way. But unfortunately, not everyone knows as much about PBC as all the people on this call, and I mean all the people on this call. So, I know. But just remember, if somebody says you can't take these in liver disease, ask them about the Lancet, the New England Journal of Medicine, published these trials, so they're very well conducted trials. A chap called Phil Newsom, who was in Birmingham, is now in King's, very good UK hepatologist, did the trials. They're very good trials. These drugs are clearly very safe in non-cirrhotic people with liver disease, and generally, without sounding daft, fatty liver disease is much more like a liver disease than PBC is. PBC is a disease of the bile ducts, not of the liver. So actually the liver is much better in terms of its function in PBC than it is in fatty liver disease. So if something's safe in fatty liver disease, it's going to be safe in PBC. But that might be too much information for the average person who says, computer says no.
Yeah, and I think that's potentially what's happening, isn't it? Because of
I think so. Computer says no.
Yeah. Right, just before we move on to our next question on the list, I'm going to get a question that's in the room here. It says, they've been experiencing a lot of pain due to osteoarthritis, been prescribed 400 milligrams of Celebrex daily for 2 weeks. Is this okay? I have no cirrhosis or fibrosis.
Give me 2 seconds, because we don't use trade names. So I'm just going to double check what Celebrex is. Talk amongst yourselves for a second. Weather's terrible, isn't it?
It is actually. It's absolutely shocking.
Celebrex. Okay. Ba-dum bum bum ba-dum bum bum. Bum 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 bum. Okay, so Celebrex, I thought it's a drug called celecoxib, which isn't widely used anymore. That essentially, one of the problems with it's a non-steroidal. Okay, so the short answer is it's fine in PBC, and the slightly longer answer is it's a funny drug because it was always said to be the non-steroidal that didn't give you stomach problems. Okay, people will be very familiar that one of the reasons why people can't take Brufol or something like that is you get stomach irritation, up to and including ulcers. So it's a significant issue. And celecoxib or Celebrex was developed as a way that would give you all the benefits without getting stomach problems. Basically, that really wasn't the case. It kind of, it was good marketing. And so it's largely been withdrawn, actually, because it didn't do what it said on the tin. There are still people around, and I suspect this might be what's happening here, who continue to take it because it worked for them. So this often happens, if in a population terms, there's no reason to have a drug available, but there are people who get benefit from it. It's disingenuous to stop it in people. It often surprises people that thalidomide is available as a drug in the UK. Why? Because there are some people with some autoimmune conditions who do very well with it, but nobody's going to be started on it for anything other than very specific reasons. So there is no reason. I haven't. I mean, I thought it was that, but I was just double checking. I haven't used it for a long, long time. There is no reason why you shouldn't take it. Sometimes it's one of these urban myths that arises about certain drug types. And I do hear all the time from people that they've been told they shouldn't take non-steroidal anti-inflammatory drugs with PBC. Have you heard this, Mo?
Mm-hmm. Yeah.
There's no rationale to that at all. I tell people that actually, if you have got arthritis, and I speak as somebody who had a knee replacement early this year, so I feel your pain. So generally speaking, where people have got those irritating joint problems, which you do get with PBC, taking just a low dose of Brufen first thing in the morning to get going is actually the best thing to do. But don't take it intermittently. Okay, if don't take it intermittently. So if you are getting that pain, take a fixed dose every morning. I just used to take 2 tablets a day every morning, and it sorted my joint pains out until I got surgery. And that's exactly what I recommend to people. If you have got the hand and the foot joint pains, take some two paracetamol, 2 Brufen in the morning, but do it regularly. And there's no reason at all why you can't take non-steroidals in PBC at all.
Great, thank you. Our next question is from the list here, and it's: I'm a middle-aged man in the UK, recently diagnosed with PBC about 4 months ago. Currently on the correct level of Urso from day one and take it correctly.
Yeah.
My ALP so far over 4 months has remained at above 400 with little or no movement, although I know it's early days.
Yeah.
ALT and gamma are also at least double upper level. Bilirubin levels are all well within normal.
Yeah.
But I've also been told I have portal hypertension.
Yeah.
FibroScan score was 10.1, CAP score 238, and classed as F2 according to the hospital. I also have below the range on platelet counts, hemoglobin, red blood, and white blood, and also have B12 pernicious anemia. But I've had the course of B12 injections.
Yeah.
So the question is, on my last hospital notes, it states portal hypertension cirrhotic. I'm a little confused, as if my FibroScan score is 10.1 and F2. Doesn't that mean I just have fibrosis currently and not cirrhosis? And should I be concerned at this stage? And although already be looking at second line treatment, can you have portal hypertension without cirrhosis itself?
So that's a very, very good question. And my first and overarching comment is that if you're not being seen at a centre that knows how to manage PBC, you need to be being seen at a centre that knows how to manage PBC. Now, we talk about this all of the time, and PBC comes in lots of different flavours, and everyone deserves good care, and people who understand the disease and all of those things. And there's a balance between travelling and convenience and expertise. But there are certain situations where it gets complicated. And in those complicated situations, you're best off going to one of the centres. And I'm not criticising any centre, but there are certain places that, really specialise in PBC. So Birmingham do it, Newcastle do it, Edinburgh, Glasgow do it actually now. King's do it in London, the Royal Free does it. And some other places. And I think that the reason is that as I said, some people are just complicated. Okay, and it is very clear from what Mo has read out that you are very clued up on PBC. And that's the other thing, is that because that's a perfect description of a clinical state, speaking the language I would be familiar with. And the other part of all of that is that there's a danger if you're seeing somebody more general that you're going to ask them questions that they're not able to answer, and that doesn't work very well. So for all of those reasons, you're the sort of person that should be seen at a specialist centre. And you just look at Newcastle. We have 3 consultants. We run 4 or 5 PBC clinics a week, and we have 3 consultants who have a main focus on PBC. The reasons why I think it's really helpful to go to a more specialised centre would be threefold. One is people who are heading towards transplant, which you're not, by the way, but it needs focus. So anybody around and about transplant go early so that you can be into the system nice and early. That's an obvious one. The second one is about complex symptoms. So if you're having really bad symptoms which are difficult to manage, then it needs to be seen, in a slightly different light. And then the third one is questions about second line therapy, where it's a bit grey. Okay, and that's what's going on here. So let me unpick some of those things that were said. So the first thing is, it's good you've had the diagnosis, and it's good you've had the diagnosis made, and it's good you're on the correct dose of urso. Okay, it is not good that the alkaline phosphatase is above 400. Okay, now, so that makes you at face value an urso non-responder, and therefore we need to act on that. So what's going through my mind, because my mind is hyperactive and I'm always thinking all of these things through. So the first thing in this is that if I saw these sets of results, I would say, am I 100% certain this is PBC? The reason is it's very unusual to see no benefit from urso. It's one thing not getting enough benefit, but you would normally get some benefit. So I would take a step back and I would ask myself, am I 100,000% certain this is PBC? And there is a particular caveat that is important, which is that men form only 10% of people with PBC. Now, that's fine, 10% of, I don't know what the membership of the foundation is, but, it's still a couple of thousand people in the UK who are men with PBC, so undoubtedly happens, but it's less common. And so the number one thing I always ask myself is, am I absolutely certain this is not PSC, which is the other form of autoimmune bile duct disease, which is commoner in men and which does not respond as well to urso. So that's just a double check thing. Now, if you are AMA positive, then it's PBC, and it's just PBC that's not responding. But I have big alarm bells that always ring when people are AMA negative men with PBC, because I've been bitten with that a few times and it just needs a bit of a step back. So that's just a question, to ask your clinicians, are you absolutely certain this is PBC? So the next thing, so a FibroScan of 10 and change, if you like, is not cirrhotic, okay, is not cirrhotic. The cutoff we use is 17.9. And just to put this into perspective, normal FibroScans, your liver has, it has a structure to it, otherwise it would be mush. And so everyone has a FibroScan value. So 4 to 6 is normal. That's the normal value. So you're kind of, in a sense, nearer to normal than you are to cirrhosis, right? However, that is clearly abnormal as a value. And it's very interesting that there's some work from the Paris group, a guy called Christophe Corpechot that many people will have come across. So he is a really thoughtful PBC expert, and he's done a lot of work around cutoffs in FibroScan and what we should do. So almost everything we do in practice around FibroScan comes from the work that he's coordinated. And he's the one who came up with 17.9 as the value for cirrhosis. But he says 10 is the magic number. 10 is the magic number that you need to take really seriously with PBC and make sure you're doing the right thing. So you're right at that point, which is mainly why I said you need to be seen in the centre that knows the nuances of PBC. So the fact they've said it's F2 maybe implies you've had a liver biopsy, or it might be extrapolation from the FibroScan, but it sounds about right to me. FibroScan of 10, F2 is probably, that's right, and you're right, F4 is cirrhosis, and so this is not cirrhosis, right? So portal hypertension, okay, portal hypertension. So portal hypertension means the risk of developing varices. It's a complication of cirrhosis. However, in PBC, you can get what's called non-cirrhotic portal hypertension, right? So PBC patients can get portal hypertension without cirrhosis. A FibroScan of 10 is a bit low for that, okay? You would not think that, and you'd be a bit surprised at that. Sounds a bit odd. F2 is a bit early for that. It's kind of F3 FibroScan of 13, 14 is the sort of place you see non-cirrhotic portal hypertension, but you certainly can have it. So the question then for me is, on what basis did they say there was portal hypertension? Now, if they've done endoscopy and you've got varices, they're clear cut, and somebody's taken a picture of it, and somebody else has had a look at the picture and said that's varices, then that's varices, and it is what it is. However, there can be, misinterpretation, and people can interpret, and we still see people who are, where clinicians interpret the abbreviation PBC as primary biliary cirrhosis, and they put 2 and 2 together and make 20 and see something that isn't there. There's an old saying in endoscopy that what you see at endoscopy depends on what's at both ends of the endoscope. So the less experienced an endoscopist is, the more that they can fall into these traps, and quite early varices can be mistaken. Did you say what the platelet count was? I missed it.
He says, I also have below the reference range on platelet count, hemoglobin, red blood and white blood cell.
Yeah, okay, right. So, low platelet counts, but it's part of but it depends what the level is. So it is possible that there's non-portal hypertension, non-cirrhotic portal hypertension, okay? However, that just needs proper treatment. Now, the kicker here is that almost all the therapies now for second-line treatment in PBC say that you shouldn't have them if you have portal hypertension. So this is not an arcane argument. This is really important. Now, do I think we should never treat people with second-line therapies who've got portal hypertension? Absolutely not. But you would be going off the label for the drug, and that needs people who are really confident in what they're doing. So that's the other reason why you need to be seen in a PBC therapeutic centre. So we've absolutely treated people with far worse liver disease than this with very good results. But there are cautions out there about how you do it. So this is tiger country. And if you're in tiger country, you need a good guide to guide you through. So that will be my main advice. So we see people with these sorts of stories all the time, but that's because we're a specialist centre who deal with this. And that's not a criticism of the centres. Other centres are really good at other things, but this is, as I said, it's and the foundation can give you, in a way I can't really, about who are the people that we're kind of talking about with all of this. But there are people who kind of know this inside out, and they're the sorts of people who pop up on a Thursday afternoon answering questions, and they do that for a reason, because this is what we do. So I think I would advise you to be seen, because they need to get this right. Just as an aside, men with PBC, there's a swings and roundabouts element to it. So men with PBC are less likely to be symptomatic, but they are more likely to be non-responders to URSO. And so this is a picture that we are familiar with. But if I were with that picture, and this is definitely PBC, then going back to our old friend, risk and benefit, okay, the risk of having second-line therapy with portal hypertension is not great, right? It's there. It goes back to how can I prove a negative? I would, if it were me, I would absolutely, definitely have second-line therapy, but I'd want to have it given by somebody who kind of knows that you're a little bit in tiger country. There's nothing to worry about with this. This is all manageable, but it's kind of, it's big boy, it's big boy games, big boy rules. And I think that would be the perspective. And that would fit, I think, with the foundation's guidance, is that there's a balance between convenience and familiarity versus expertise, and you need to strike the right balance. Who are I've given many lectures over the years, is, to clinicians, who are the sort of people that you should be managing, and who sort of people where you should be getting some assistance with management. And that, as I said, perfectly outlined case story is just the sort of person, because if you wade in and make mistakes and things, then, you're going to get out of your depth very quickly. I hope that's useful.
No, that's
I
great.
just say,
thank you.
Just on that note, is that is a perfect summary of a clinical case. And that's somebody who knows their numbers, right? And we go on all the time about know your numbers, because that is what gets people to get attention. And you've given some very specific numbers. On that basis, I've given some very specific guidance. But, know these numbers, because it will hold clinicians to account.
Definitely.
Would you agree with everything I said there, Mo?
Yeah, and I think it's just known as reading that as well. It does. You just see how our patients are really involved in their own care, and they understand what things are, and they know the right questions then to ask if they're querying anything, So,
I mean, it's very interesting. We get a lot. I mean, obviously, get a lot of referrals from GPs, and most referrals we get are brilliant, actually. Certainly in our region, where they outline all of these facts in it. I mean, not FibroScan, obviously, but because that's a hospital thing, and they just bang, 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 they delineate the entire story, and you think to yourself, they know what's going on, and they just want their hand-holding about management. And the other times you get, there's something wrong with this person, I don't know why, they can't be bothered, brackets, I can't be bothered to do anything about it, and your heart sinks a little bit, because you know that everything is going to be a battle with it. So own it, and that way you get people to take it seriously. And also, Warren Buffett's famous saying, it's only when the tide goes out you realize who's swimming without any trunks on. So a lot of doctors will have a lot of bluster and a lot of trust me, I'm a doctor sort of stuff, but when they don't know what they're doing, and when you ask them specific questions, it becomes very clear when they don't know, and that's when you go and ask for a second opinion. No PBC expert in the country, I know them all very well, trained most of them, trained all of them, because I'm very old. No good PBC clinic in the country would bat an eyelid at taking that as a referral. They would say, all say, that's why we're here.
And also, just on that, we're here to help support you with your planning for your medical appointments as well. So if you need some support to put together some questions, we've recently produced some new resources as part of PBC Day this year, and also as part of Project 9090, which is launching soon. So on our website, or we can get them sent out to you as well. We've got a resource for preparing for your clinic appointment, and we've also got a document helping you discuss your care with your clinician as well. So making sure that the right route's been taken, and when potentially you might need that referral. So please make sure you have a look over those. They can be really useful for you taking into your clinic appointment as well, especially if you're at the point where you feel that there are some unanswered questions and you want to try and move things along.
I mean, we can help with that. Second opinions all the time, and it's and it's all about, you've got to have confidence, and please don't die of wanting to be polite to your doctor. I keep saying to people, we need to be in love with our inner American. And I shouldn't say this probably, but there was somebody not getting very good clinical advice by, and this is where consultants do it wrong. I've been talking about this, several people, is what happened. Why do things go wrong in medicine? Well, they go wrong because people make the wrong decision, and then they double down on it and treble down on it and quadruple down on it, as if, and I'm an academic, and maybe that, we question everything we do. I mean, we always question what we do. That's why progress arrives, because if you don't question what you do, you're just stuck with what you've always done. And it's where the consultant's doubling down and telling people they're wrong. But the best example I came across recently was somebody that was happening to somebody all the time. Their hair was, they're pulling their hair out, and so Robert went with them to their consultant appointment. I mean, that's not a service that's offered by the foundation, but I quote that example because you can, as a patient's organisation, you can do lots of different things, can't you? You can write leaflets, and you can, do policy, and you can lobby, and you can, support research, but you can also roll your sleeves up and really get engaged. And I think one of the things I love about the PBC Foundation is it does all of those things, because all of those things are important. But if you do the posturing and the erudite policy stuff, but you don't also roll your sleeves up, it can sometimes feel like you're a little bit above the fray. And I'm going to tell you a story that will horrify you, okay? Is that there is, in the area of rare disease, so PBC is a rare disease, and the term rare disease actually has a technical definition to do with care provision and things like that. in sort of healthcare systems. And I was talking to a charity that works in rare disease, and they were talking about lobbying the new government and, you know, holding receptions at Westminster and all of that. And I sort of said to them, is that's all great, but, you know, what really bothers people with rare disease is the care that they get and how they can get that. And, you know, people who come and talk to us are worried about, you know, what's going to happen to their mum, you know, in practice. And this charity told me, oh, we're not really here to sort out what happens to your mum. We're kind of doing more important stuff. Okay. And I said, actually, that is the important stuff. You know, once you've got that sorted, then you can do the other things. And it was the most condescending thing I think I'd heard in a very long time. I've ceased to work with that organisation. That is not my value set at all. Yes, all of that's important, but if you ever lose connections with the real world, then, you know, and this is the real world. As I said, that you know, I've been involved in the foundation for a very long time, but it's because it does all of that it's powerful. I just think that Robert going to a consultation is just brilliant. I mean, that is.
I would love to have been a fly on the wall.
Well, quite. And it's about, and it was just a consultant who would not listen. Okay. And I just think that's brilliant. I mean, I too would have liked to have been a fly on the wall, but that's where you put your money where your mouth is. Okay.
And that's why we're here for you as well, in terms of things like planning for clinic appointments, or if you're unsure that the advice you've been given is right. I think that's why these sessions have remained so popular, and so popular to the point where we have questions that are now lying over maybe 2 or 3 weeks, because you know, we get such a lot of questions both in advance of the sessions and then live when we're running as well. So they're really popular.
You very politely haven't made the points because I talk too much. I've done a lot of sessions recently, and I talk too much. So
I would never say that. I would never say that.
You're very nice. That's why, Robert. Last week we actually went straight into the quickfire round, and for those of you who are new to this, you'll realise that the quickfire round is a psychological battle between myself and Robert, where he wants quick answers and asks quick questions, and then I just talk around. But the answer to that actually is to have more sessions and to go, because these are, I mean, again, you know, I always say this, these are brilliant questions, and there's always something we can take out from a very specific question to generalize it. And if you, the reason why we like these sessions is that, you know, if we were to map out the things we want to talk about, you wouldn't cover most of the stuff that comes up, but they are just, you know, good talking points, and it's just worth unpacking them because there's always a sort of a thread that's worth putting out. Having said that, we can do quickfire round now if you want.
No, because I think what's useful as well is I quite like having the opportunity to make our little mini videos as well. So then if someone queries something in particular, we can point them direct to a short video that they can listen to, and not a longer session as well. So that's been really useful over the last wee while as well. Right, let's see if we've got any in the Facebook chat. We can do quickfire for you.
I mean, having said all of that, actually, when Robert does quickfire round, he'll get to 1 minute before the end, and the question will be, "What's the meaning of life?" or something. So he always ambushes me with something which is literally impossible to answer in 1 minute. I'm
going to try and do a couple of quickfire from Facebook, and then there's a couple of questions in the chat here, and that'll be our plan for the remaining 10 minutes. Okay, so with someone just in our chat earlier around COVID, we've got someone who's tested positive yesterday for COVID. How long would you suggest they wait? I think is it there's a certain amount of weeks to wait before you can then go for your injection, isn't there?
I would wait at least 6 weeks.
6 weeks, perfect. That's great. So we've got that one. So that was a 2-word answer. I'm taking that as a quick fire. We've got someone who's tested positive. They're just noting that they've been on the antiviral treatment. Always ask about that as an option for certain conditions. ALT is 56. Is that bad?
In what do we know the context?
Nope, just ALT.
I mean, ALT. We always talk about alkaline phosphatase, and that is the most important of the tests. But ALT is usually elevated in PBC. And in somebody with PBC, an ALT of 56 wouldn't particularly bother us. I mean, it's part of a picture.
Right. Now, there is one question on Facebook that I would like to come back to, and it might take a wee bit more than a quick fire, but I'm going to just go to the ones we have in the room here as well. So we've got a question around if liver doesn't have nerves to cause rib pain. Spoke previously that is encased in a capsule that does have nerve ends. So question is, if PBC affects bile ducts, and as long as you don't have NAFLD or cirrhosis, then why do we get pain in the liver?
Yeah,
PBC?
because why'd you get a dull ache in the right of your tummy? And everyone used to think it's gallstones, but it kind of isn't, because most people with that dull ache don't get gallstones. So the liver cells, the liver tissue itself doesn't have nerves, but the capsule lining it does. And if the liver stretches, if the liver swells for any reason, it stretches the capsule, and that stretch is what gives you discomfort. Okay, so it is not the liver, it is the lining of the liver. Although you won't typically get that after liver transplant, because you've cut the nerves to the capsule, right? So it is the liver swelling a little bit, which stretches the capsule, which gives that discomfort. Now, in my experience, urso or second line therapy, if people need it, usually sorts that out, because it reduces the swelling, because there's less irritation in the liver. So that sort of gripey right-sided pain is the capsule stretching. It's nothing to be worried about. It's part of PBC, but it's something that tends not to be thought about. That was moderate.
That was good. So I've got a question around anything specific should ask my consultant when I see him on Monday when I am having a biopsy. ALP is 702.
Yeah.
Gamma GT 817, AST and ALT 86, bilirubin 33.
Yeah.
On URSO and OCA.
Yeah. So clearly, the target. So normal for alkaline phosphatase is 130, okay? And we are, in conventional sense of normal, of an effective response, is 210. Although, as we've talked about many times on these occasions, we are going to move increasingly towards wanting to see it below 130. But the orthodox current established view is you want somebody to have an alkaline phosphatase below 130, okay? So your alkaline phosphatase is very elevated, right? And there's no two ways around that. Now, you are on URSO and OCA, and that's the right thing to be. So that is first and second line therapy. But you need more, okay? All things being equal, you need more. And I think the fact you're having a biopsy is a very reasonable thing. So we don't routinely biopsy people with PBC. That was the wrong thing to do. People did that in the past, and it was the wrong thing to do. But it is absolutely the right thing to do in certain situations. And if you don't know quite which way to go with treatment, it's the right thing to do, okay? It's the right thing to do. And so there are certain questions about the nature of the disease there, which are very important. So is this pure PBC? Is there a bit of autoimmune hepatitis there as well? Those are very important questions. So that's a really important question. If this is pure PBC, which is so I think the biopsy is the right thing to do. I'd do a biopsy in this situation. What would I do if this is pure PBC and you're on URSO and obeticholic acid? I would add in bezafibrate, okay? So we increasingly use what's called triple therapy, which is URSO plus OCA plus bezafibrate. And I have to say the effects of that are extraordinary in terms of normalizing the tests. So if you think that OCA and bezafibrate both do kind of similar-ish things, it's interesting. It's not a doubling. If you give two, it's a quadrupling of the effect. So they seem to interact with each other in terms of the key process. So, and again, there's not a single PBC expert in the country who wouldn't go to triple therapy at this point. I would not stop the OCA. Face value, the OCA hasn't does what you want it to do, but it's the combination that's key. So the very specific thing to say is, after the biopsy, is this pure PBC, or is there something else going on? That's one of the reasons that we're doing the biopsy. And would I benefit from triple therapy? And you need to be nodding your head very vigorously. And in our experience, this is a game changer.
Sorry to interrupt, but there was a little update there in the chat here, just to say that they've been on bezafibrate but couldn't tolerate it, and they're 7 years post transplant.
Now, okay, that does complicate things, right? So 7 years post transplant, 7 years post transplant raises the possibilities of other causes for the liver function test abnormality, in particular bile duct related problems. So biopsy and MRCP become very important, because you've obviously had an anastomosis, which stitches the bile duct together, so that can narrow up. So as well as but I would imagine they've done that. If you go into biopsy, we would certainly do that. So you need to have your bile duct properly imaged in a way you wouldn't need if you hadn't had a transplant and then a biopsy. Recurrent PBC, which is what you say this has been labelled as, it is. We're a little bit careful with recurrent PBC. Why? Because there are lots of reasons why alkaline phosphatase goes up after a liver transplant, and AMA never goes away after a liver transplant. And given that abnormal LFTs and AMA is the diagnostic thing for PBC, anybody technically after a PBC liver transplant will look like they've got ongoing PBC. So I think it's absolutely right to have a biopsy for those reasons. So there are lots of potential etiologies with it. If it's true recurrent PBC, there is no guidance about how to treat it, okay? There is no guidance about how to treat it. We would, however, if we're worried about it, treat it the way we would treat PBC. So some centres use a lot of OCA. We don't tend to use it. We don't see much recurrent PBC, but I think OCA is a very reasonable thing to have, OCA plus URSO. If this is, if you're intolerant of bezafibrate, then the question would be, in what way were you intolerant? There are different ways of being intolerant, and it may well be that you could use the combination of fenofibrate, and so we would often use fenofibrate as an alternative fibrate. And then, of course, there is the option of the newer PPAR agonists, which are better tolerated than bezafibrate. Now we're going way off piste here now, because they've never been used post-transplant and not been used as combination therapy. But I don't think any of us doubt that the combination of OCA plus either elafibranor or seladelpar plus URSO will be the definitive treatment for PBC. So I think that's one to both have a chat with your consultant, but also have a chat after the biopsy has come along. And clearly, if this is just recurrent PBC, you need something more. If this is something else, then you need, an appropriate treatment around all of that. And is there any mileage for elafibranor as well? We are starting to use elafibranor on the named patient program, so we're starting to do that. But that's a very specific discussion.
Okay, I would say to the patient who asked that question is, once you've had the biopsy, if you've got any other questions, please reach out to us on the helpline, and we'll see what we can, if there's any other information, and then we can pass that on as well. Right, last question, and it's based on what you were talking about earlier. So someone's put a question into Facebook for us that says, how do you go about getting referred to a specialist clinic, please? I have a 5-minute annual telephone appointment. Last appointment, the consultant didn't have access to my blood results, so I get concerned about my care sometimes. And it's something that went through my mind when you were talking earlier about getting referred, because we do often get that from patients to say they would like to be seen under a specialist centre, but it's not often the easiest thing to happen. So what would your advice be there in terms of people getting that?
Yeah, so every region of the country has a kind of referral network for it to do with second line therapy. So every hospital refers into what are called the operational delivery network. So these are the centres that decide on second line therapy. Now there are 22 of those, and all 22 of those are not out and out specialist centres. So each of those 22 centres has a super specialist centre that it refers into. So, we cover the whole of the northeast of England. And so there's kind of a route through that system for people. And then obviously, GPs can refer to whoever they want to. So what works for me, I mean, the best thing to do is to talk to your consultant if you can get to do that. And I appreciate that's difficult if you're only getting a 5-minute telephone conference. There is literally no point having a review appointment on PBC without the blood test. There is no point. It's like a blood pressure review without the blood pressure. So what I would say then, and so the other options are, so if that's difficult, so is it possible to go to a PBC specialist centre? Is a perfectly reasonable question, right? And at the very least, they will, and if they can't tell you what's going on with their disease, it's kind of difficult for them to argue not to, right? The two other things to do. So in the NHS, right? NHS Constitution, bless it, you have a right to a second opinion, right? People have a right to a second opinion, and that's fundamentally that has to come from the GP. It's nothing to do with the permission of the GPs. Often say, "Oh, that's got to come from the consultant." No, it isn't. It's a GP. Your GP is responsible for referring you in for specialist guidance. So if it's you're not getting anywhere, you go to your GP and say, I would like to request a second opinion. Now, any good consultant will recognize that relationships break down with people for whatever reason. It's happened to me. I'm not some panacea and perfect in every way. I mean, I know you find that difficult to believe, but I've had people who've stopped kind of believing what I'm saying. And in those situations, it's better that somebody's colleague sees them. It's just better for everybody, right? Because if people don't believe what I'm saying, or kind of, I've said something would happen, it didn't happen, or whatever, then, it happens. It's life, right? And so you're better, if you go have a rubbish experience at Tesco's, you get Sainsbury's, don't you? So there's nothing wrong with that. And so most consultants would recognize that. And I've certainly facilitated people, to go and see somebody else because it's the best thing for everybody. There's no rancor there. It's not a macho thing. So GPs should recognize that. And then the other one that's very useful, to be frank, is to ask to go to a centre that's active in research in PBC. Okay, and that's usually the one that works. So wherever we've done this, and people have found it difficult, is to say, I'm perfectly happy with my care, but I'd really like to take part in PBC research programs. And I'm aware that there are a large number of research studies going on, research into understanding PBC and how to treat it and all of that. Would it be possible to be referred to one of the centres that runs a research or a trials program? And that just allows everyone to kind of do it without it implying that people are unhappy. Okay, so that's my little trick. Can I be referred to a centre that is very active? And I get a lot of referrals like that, and GPs seem happy with that. Seems perfectly reasonable. Remember, you have a right, and here we go, NHS Constitution, you have a right to participate in research. Okay, it's not a luxury. You have a right to participate in research, be informed of the research that's relevant in your area, and a right to take part in research. So all you're doing is exercising that right. 85% of people who come to our clinic take part in one or more research projects. Okay, 85%. So the NHS talks about it's okay to talk about research. No, it's not. It's essential. You shouldn't have to talk about research. It should be everywhere. It's absolutely part of what we do. And I think that's very important. So you have a right to go to a centre that is involved in research. And I think it's just a kind of way, we all kind of know what's going on here, but it's a way for people to save face, and it seems to work well in practice. On that note, my bing bong for my next meeting has gone up.
Thank you so much again for your time. We really appreciate it. I just want to say to everyone, if we have got a question outstanding for you, please know we will get to it. I'll pick up any in Facebook that have not been asked today and add them onto our list as well for next week. Thank you so much, and we'll see you again soon.
Oh, no doubt about that. Okay, see you later.
Take care. See you later. Bye.